Okay, so without further ado, let's start the webinar. I will share my screen with you, and I will very briefly, as I said, introduce the project. Okay, is it visible?
It is.
Okay, perfect. Thank you very much. So the Resistir is a project, is a Horizon 2020 European project that aims to understand the impacts that the COVID-19 pandemic and respective policies had on behavioral, social, and economic inequalities in the EU 27, along with Turkey, Serbia, Iceland, and the UK. It does so by mapping policies and also civil society initiatives, together with collecting quantitative and qualitative data, which are later translated into operational results in the process of co-creative workshops. The project relies on a multidisciplinary consortium of 11 European partners and a well-established network of national researchers in 30 countries. How it is organized. So the project builds on an intersectional gender plus theoretical framework, meaning that we are looking at the intertwined effects of different inequality grounds with specific inequality domains such as education, healthcare, gender-based violence, and so on. The overall methodology of the project is based on a step-by-step process running in 3 cycles over the period of 30 months. So the project started in April 2021 and it will finish in September 2023. This is why a month from now we will be organizing a final conference of the project, but I will say a few words about that at the end of today's webinar. For the moment, I would like to just very briefly, as I said, explain how we produce our results. So as I mentioned, the project is organized in 3 cycles, and each cycle builds on the insights deriving from the preceding one. And it leads to the production of operational results. There are 3 of them: pilot projects, research agendas, and operational recommendations for policymakers and other relevant stakeholders. Today, during our webinar, we will focus on one of the examples of policy recommendations that we produced. They concern the issue of access to health services for vulnerable groups, and how those intersecting inequalities in the area of healthcare are hindering access to health services. So right now I will give the floor to Lorenzo to very briefly introduce you to the results of our project related to the topic of intersectionality and healthcare.
Super. Thank you, Agnieszka. Should I share my screen?
Yes, just give me a second so that I can stop sharing mine. Okay.
All right, let me see. Yeah. Present mode. You can see that, right? Yeah.
Now we can see the notes mode.
I see the notes mode. Use slideshow. There you go. That works?
Yes.
Super. All right. Thank you very much. And thank you for being here. I'm Lorenzo. I'm part of the Resistir team for C and Sano. And As Agnieszka mentioned, I'll talk to you a little bit about the results from this from the last part of our work, which tries to propose problems and solutions to those problems. And the problem we're talking today is access to health services for vulnerable groups. Just a brief overview. Right now, I'll present to you what access to health services means for vulnerable groups and some insight from this to right. And we'll talk about recommendations from our work later on. And we'll have a chance to discuss them as well. So when we're talking about unequal access to health and care, this stems from part of our research looking at the problem of saturated healthcare systems in European countries, which postponed most of non-urgent care and made hospitals hard to access for cures that were not very related to COVID-19. And this is a reality that everybody faced, regardless of gender or sexuality or socioeconomic situation. However, some services and some groups experience more barriers than others. And part of our work was able to see that sexual and reproductive health was not considered primary care in every country, and this created a first obstacle of access to one part of the population, as well as that and the problem that discrimination and stigmatization based on sexual orientation, ethnicity, or other socio-demographic features made people more reluctant to look for help. So from one end, we have the problem related to less access to these services because of the public health emergency. On the other hand, we have the problem of a population which is less able to access these services because they feel scared of repercussions, or simply because they do not know how to access them because of a lack of communication. So the conclusion that came from this analysis was that even where access to care is universal and with very few economic barriers, which is the case in most countries in Europe, social and demographic attributes hinders people's ability to access the healthcare system. And from this, we tried to understand what happened to the actual healthcare system. And there are a couple of causes that made this possible. One is, of course, the decrease in public health spending, which contributed to a less prepared health system. This goes hand in hand with the fact that a less prepared health system is also less flexible to the myriad of necessities that primary health means for different people. And then, of course, the increased privatization of healthcare and specialization of health systems made non-communicable diseases a lot harder to fight, especially a pandemic that is respiratory based. So this resulted, of course, in less resources available to fight the pandemic. And then a lack of updated and coordinated pandemic plans across Europe in every country contributed to this low response and adaptation to the public health emergency. So these are strict public health and epidemiological mechanisms that really made healthcare systems slower to respond. Of course, as an overall, there's countries that were a lot more prepared than others, but that's a more complicated question. And then from this is the concept of what reduced care and lack of access mean for the whole population, because primary care, first and foremost, does not have a standardized definition in every country. So there were a lot of countries that included some therapies and included some treatments as primary, and others that didn't. At the same time, the state of emergency allowed some conservative governments to restrict and attack sexual and reproductive rights in some cases, and SRH is really the area of health which has the most gray and the least accordance across European countries on the importance on what constitutes as primary care and what doesn't. And of course, there's populations which are often considered hard to reach from healthcare systems and as a base, because they're really impossible to keep track of during and becomes even harder to keep track of during the pandemic, which were further moved away from the healthcare system because of a myriad of problems, which is our stigma and discriminations, which of course contribute to hindering access to this population. We can think of the fact that in a lot of countries, you need to be registered in a central system in order to access the healthcare system. People might not know that emergency care does not require this registration, but still this incomprehension leads to a reluctance in looking for help. There's also the fact that messages regarding the pandemic and its containment measures were often not translated in the language of minority groups. I can think of, off the top of my head, the example of Sweden, which had this very big and efficient campaign for a long time, and then they realized that they didn't translate it in the most important languages of the communities which were being affected the most. So they relaunched the whole communication campaign in different languages other than Swedish. And then we have measures for at-risk workers not in the healthcare sector, which were slow to adapt to the pandemic. And of course, within this group, there's a demographic which is often already more at risk because of general risk factors in their work. And the added pressure of the pandemic made it a lot harder for them to respond, also because it's often works that do not have a protocol to respond to a problem like a public health emergency. And Agnieszka, I think I hand it back to you from here, right?
Thank you very much, Lorenzo. Thank you for this recap and for sticking to the assigned time slot. So right now we will move to the most important part of today's webinar. So we will listen to testimonies of representatives of 3 different civil society organizations, 3 different projects. Each of the presentation will be lasting around 10 minutes. And I will introduce each of the speakers one by one. So right now, I would like to warmly welcome Karen Muli, who has been working for the Christian Health Insurance Fund since 1998. Her focus areas are patient rights and advocacy, and since 2021, she has been working as the federal coordinator of the Intermutual Community Health Workers Project in Belgium. We have 2 representatives of this project today with us, and following her presentation during our roundtable discussion, Karen's colleague Matthias Nielen will also join us. He started working for the Socialist Health Insurance Fund in 2012. He focuses on accessibility, affordability, and quality of healthcare in Belgium. From the start of the COVID crisis in 2022, he contributed to the intermutual management of field agents in Flemish contact tracing. And since 2021, he is active as deputy coordinator of the Intermutual Community Health Workers projects in Belgium. So now I would like to give the floor to Karen to tell us a little bit about this initiative and their experiences during the COVID-19 pandemic.
You see my screen? You can
yes,
see my
we
screen.
do.
Yeah.
Yes, yes,
okay, that's good. Hello, everyone, and thank you for the introduction already. And I want to start also by thanking you for inviting us. And we are, of course, also very honored that our project has been listed as Better Stories. Now, I will very briefly explain the project and share with you some lessons learned over the past 2 years. Okay. The Community Health Worker Project owes its existence, strange as it may sound, to the COVID-19 pandemic. This pandemic underscored an existing challenge, namely that primary healthcare is hard to reach for socio-economically vulnerable groups. The trick is, however, to turn every setback into a new opportunity. And that is exactly what the Federal Minister of Health, Van den Broeke, has done in Belgium by launching the project in response to this challenge. The first results of our project are promising. Access to care for the most vulnerable was already a problem before the pandemic. So we believe that we must seize the moment to ensure that the community health workers form a sustainable part of the Belgian healthcare system. The project is supported by all health insurance funds together and implemented at the federal level. We are present in 3 regions of Belgium, Flanders, Wallonia, and Brussels, with a total of 50 community health workers. But who are the community health workers? The community health workers are lay health workers. Generally, they have a very diverse and extensive life experience, such as their own experience of poverty, refugee experience, or still war trauma and family reunification. Or they have themselves faced uncertainty or difficulties in accessing care. A community health worker is characterized by soft skills, such as being able to start a conversation easily, being a good listener, and engaging in a conversation in confidence, respecting and taking an interest in other lifestyles and views, working in a solution-oriented way. Even though we did not have specific degree requirements at the time of recruitment, it turns out that a large proportion of the community health workers are highly qualified. They all speak a wide range of other languages, in addition to Dutch or French. Due to the diversity of cultural backgrounds, 15 different languages are spoken in the entire Antwerp team, for example. A wonderful group of driven people who contribute to achieving our goal. Namely, improve accessibility to primary healthcare for underserved, vulnerable groups in socio-economic vulnerable neighborhoods. By vulnerable groups, we mean people who find themselves at the crossroads of several vulnerabilities, like living in poverty, low educational status, newly arrived immigrants, living in social isolation, all vulnerabilities that are intertwined and can reinforce each other. Because of this socially vulnerable situation they live in, they experience all kinds of obstacles in their access to primary health care, which is hard to reach for them. To achieve this goal, we set 7 major objectives, which are also reflected in the roles of the community health worker that I will come back to later. Our project was also fortunate to be supported from the start by Caroline Masquier, a researcher with enormous expertise, passion, and a warm heart for community health work. This led to a first research report in 2021 that started from the theoretical framework of access to care by Livec and colleagues. Key conclusions of the study were that community health workers reach a diverse group of people living in socially vulnerable circumstances. They offer valuable contribution to improving access to care along the continuum of care. They adapt their support to the needs of the individual across the access to care continuum if needed. For community health workers to be able to do their work properly, a supportive framework is needed. However, building that framework to best support community health workers in their work takes time and resources. Important supportive structure was led in the first project year, on which we continue building. And last but not least, a long-term perspective and sustainable funding are important. Of course, there were also important areas for improvement that we started working on at the beginning of the second year. And one of these is the definition of roles, which we have sharpened. We identified 8 roles for the Belgian community health workers. a bridge builder between individuals, communities, and care and welfare professionals, provision of culturally appropriate healthcare information, navigating the healthcare system, providing coaching and social support, standing up for individuals and communities, strengthening health literacy at individual and group level, outreach efforts, participate in evaluation and research. Even though we are only on our third year of work, it's clear that we have already learned quite a lot. First of all, the adaptability, flexibility of the community health workers is an important skill, just like their ability to build trust. Not only do they need to be able to adapt quickly to increasingly fast-changing realities in society, just think of the COVID-19 pandemic and the subsequent war in Ukraine, or the energy crisis, to name a few. In addition, in order to be able to carry out quality outreach work, the community health workers often has to understand the wider context in which the request is made. Even if the community health worker should initially adapt to the specificities of the individual, he should also take into account the dynamics of the neighborhood in which the person lives and inform himself about the systemic context as well. A second important lesson is that outreach work, going to people, stepping into their environment is an important strategy. But the strength of the project consists in applying a variety of outreach strategies. This is the only way to reach the widest possible group of people living in socio-economically vulnerable situations or at the crossroads of different vulnerabilities. Outreach means proximity. This is an essential condition for offering a real answer to the needs of the target group. To be able to realize this proximity, the community health workers use different methods, such as a walk-in moment in very diverse partner organizations, such as social restaurants, medical centers, food distribution associations. They are present in the streets and squares, which allow outreach and meetings with people who are not used to going to associations or public institutions. They are also present at public events, which allow visibility to all audiences and to meet new people or local partners. And they organize also activities together with other organizations. A last important lesson that I want to share with you is that it's a constant search for a balance between such local embeddedness on the one hand and central coordination on the other. It's already clear, and we also read this in the literature, that local embeddedness is crucial to be able to adapt quickly to changing circumstances. But in addition to local connection, it's also critical to build out a fundamental shared basic structure, including an information system, management, supervision, and quality assurance. To conclude, we know that Belgium is working on an interfederal plan of integrated care. The big key question here is how we can ensure that healthcare becomes more accessible for people living in socio-economically vulnerable circumstances within the new policies of integrated care. And following on from this, the question whether the community health workers will have a place in the new system. But one thing is certain, we must do this together. Each one of us starting from its own competences, with respect and recognition for everyone's role. We are already convinced that community health workers can add a significant value in the bigger picture of integrated care. Thank you for your attention.
Thank you very much, Karen, for this wonderful testimony. I can see a lot of points in common between what you presented and what we've discovered also in our research, especially this necessity of collaboration, of working together between different actors, as well as the need of variety of outreach strategies. I think this is really crucial when we talk about vulnerable groups. I have a lot of questions, and I'm sure I'm not the only one, but I will leave them for the discussion that we will have after the presentations, so that we can be sure that each of today's speakers has enough time to present their own projects. So thank you very much for the moment. And the questions, they will be asked by me and the audience in a couple of minutes. So now we will move to Mateusz Bieżuński, who is a law student interested in sexual and reproductive health and rights. He's an activist of FEDERA, Foundation for Women and Family Planning, and professionally he researches the anti-gender movement. Mateusz, the floor is yours.
Hello, good morning. My name is Mateusz Bierzyński. I'm an activist from Foundation for Family Planning FEDERA. I am very pleased to be here with you, and on behalf of the foundation, I thank Resistere for the invitation. Okay, so FEDERA is a non-governmental organization based in Poland that works locally and internationally on the advancement of sexual and reproductive health rights through monitoring, advocacy, educational activities, and strategic litigation before domestic and international courts. We are conducting SAHR advocacy on the United Nations Council of Europe and European Union level. And today I would like to say a few words about SAHR in Poland during the last pandemic, because coronavirus was not only a health hazard, but also cause of great social and economic problems, especially for women and other vulnerable groups here in Poland. Poland has really experienced this difficult time and its impact of SAHR. Polish government instrumentalized COVID-19 measures to restrict access to SAHR with a particular focus on access to abortion. Actually, we are the only country in the EU where access to abortion have been drastically restricted. And the condition created by the COVID-19 crisis have facilitated for the Polish authorities to process leading to change in laws. Because since the 90s, the abortion in Poland was limited to 3 grounds. First, when there was a severe and irreversible fetal defects. Second, when pregnancy was a result of criminal activity. And the third, when it was a danger to women's health and life. And often under these grounds, access to abortion was hardly available. To make situation worse, in October of 2020, the Constitutional Tribunal found it unconstitutional and then deleted the ground for abortion for fetal abnormality. As a consequence, a quasi-total abortion ban has been introduced in Poland, given that the deleted ground accounted for over 98% of statutory abortion performed in public hospitals. But by the way, as you see, COVID-19 pandemic impact of SAHR in Poland should be seen the bigger picture, I think, through the lenses of its impact on democratic institutions and the rule of law. Because many Polish pandemic-related policies could be somehow justified from the medical point of view, but their legality was questionable, including government actions to stop the protest after the tribunal's ruling. But back on track. As I said, abortion was barely accessible in Poland, even under this limited legal grounds. According to FEDERA monitoring, only 10% of public hospitals contracted by law to provide abortion care were fulfilling this obligation. The outburst of the pandemic has significantly exacerbated this deficiency, because from the pandemic, beginning of the pandemic, several hospitals have been dedicated to patients with coronavirus only, while sub-gyn departments were temporarily shut down due to infections among medical personnel. And this has worsened the accessibility of legal abortion. Of course, a few hospitals provided abortion, but obviously most of abortion were induced by pills at home or in case of later pregnancies in the clinics abroad. However, the burden of providing information, help, and resources and access to abortion fell on the NGOs like FEDERA and other informal groups in Poland. But needless to say that the COVID exacerbated difficulties relating to access to services abroad. The cost of travel have been increased by the necessity to do expensive tests, made these services available only to those persons who have financial resources and who can access information on the services available. Also, abortion pills, which are not available in Poland, are quite expensive, and that's not available to girls, women, and people from marginalized communities. What's more, after the ruling, reports have emerged of denial of abortion care to women who are entitled to obtain abortion care under the law on the grounds of the risk to their life or health, further extending the obstacles that women face in the accessing legal abortion care in Poland. One of the most acute impacts of the tribunal decision is a chilling effect on doctors who risk up to 3 years of imprisonment for performing abortion outside the legal framework. To counter that, Federa forges a path with an extensive interpretation of the ground for abortion, which refers to threat to one's life or health. That so that it could cover the mental problems related to pregnancy. And regarding that, our most recent successes is the opinion of the patient ombudsman, which we won, in which he confirms that a threat to mental health is a premise for legal abortion in Poland. And we already have information that some hospitals begin to terminate pregnancies based on that opinion. Moreover, we've created and expanding until now a coalition of a woman-friendly network of doctors, mostly gynecologists and psychiatrists, who are willing to help women in this challenging circumstancing. And what I'm saying to you right now, we've been successfully communicated to the public during the pandemic. For example, from October 2020 to the April of 2021, which was the peak of COVID infections here in Poland, Federa consulted around 2,000 persons. We assisted them with all kinds of reproductive health queries, access to abortion, pregnancy care, contraception, including emergency contraception, and access to uterine devices, and prenatal testing, which is performed drastically less since the decision of the tribunal. The question we were asked also referred to the legal penalties for helping with abortion, ordering pills, legal issues around access to benefits and services after having abortion care in Poland or abroad. The limitation of SHR services resulting from the tribunal's ruling are also evident in the statistic. For example, there were 112 so-called induced miscarriages carried out in the public healthcare system during January and February 2021, while in the same period of 2020, there were 255. Okay, so as regards prenatal testing, during these first 2 months, there were 4,000 patients less than during the same period in the last year. This is due to general decrease in the number of pregnancies, but also because doctors do not encourage women to have the test done, as for the lack of options after receiving the results of the test. And it has been confirmed by many doctors that Federa spoke to, or who have been interviewed by the media. For the lack of medical assistant Polish facilities in this regard, women having any concerns as to the state of the pregnancy often decide to go directly to clinics abroad to help them with diagnostic and abortion care if needed, and that should not be happening, but unfortunately is. SHI services, of course, are not only abortion, but also access to contraception and sexual education. Poland has the worst accessibility to modern contraception among every European country. The gynecological healthcare sector is strongly privatized due to insufficient number of healthcare providers. The pandemic has severely restricted access to both public and private gynecological offices. At the beginning of the pandemic, many facilities were not prepared to provide telemedicine services like consultation or prescriptions. Moreover, general practitioners who are entitled to write out prescriptions for contraception tended to send patients to gynecologists, who were hardly accessible under the lockdown. Consequently, new private web portals emerged that issue prescription in return for 15 to 20 euros. The only non-profit initiative was Doctors for Women initiative, which provided patients with prescription for emergency contraception for free. We reacted to notifications about shortages of contraception and hormone replacement therapy in pharmacies by calling out the Ministry of Health and Chief Pharmaceutical Inspectorate for explanations. Both institutions claimed that there were no problem with the accessibility of contraception in pharmacies, which of course contradicted statistics, for example, from online databases that inform where to buy medicine in Poland. And from the mid-March 2020 until the spring of 2021, schools operated only in online mode. The Polish Commission of Human Rights observed increased inequalities in access to education. For example, when pupils could not attend online lessons because they had no computer on the internet, or when teachers were not prepared for a new format of lessons. In Poland, there is no proper sex education. Conservative SHR related narratives are proliferated as part of the school subject called Preparation for a Family Life. And there were no indications that these lessons were being properly covered during the pandemic. And I think I've already run off my time. Maybe a few words on the end.
Yeah, if you could slowly wrap it up.
Okay, so...
But no worries, you still have 2 minutes.
Basically, many of our experience resonate with your findings, and I think we could discuss it more later.
Okay, perfect. Thank you very much. Thank you for, first of all, for the work that you're doing with Federa. It is obviously a topic that is very close to my heart, especially given that I am originally Polish. It's a shame to have such a negative testimony regarding to our country, but it is great to see that there are some good practices and that there are people who are advocating for the rights of women. I will again maybe leave the questions for the roundtable discussion, and we will move right now directly to the third presentation. But I would like to remind everyone in the audience and encourage you to also write your questions in the chat if you have any, so that we can go back to them later on during this webinar. Thank you very much, Mateusz.
Thank you.
And right now, for the last testimony of today's presentation panel, I would like to introduce Tamas Gerencer, I hope this is a almost correct pronunciation, who is a policy officer of the training and policy department of the Budapest Methodological Center of Social Policy and its institutions. In this role, he has been coordinating international strategic partnership projects such as PIFO shelters, aimed to implement the principles of the psychological informed environment approach into the operation of services where women are accommodated in the organization, as well as the Erasmus Plus Women and Homeless project, in which the organization shared good practices and working methods in connection to the support of women experiencing homelessness. The development of trauma-conscious gynecological service was inspired by the knowledge gained at these projects. And here Tamas' role was to coordinate the involvement and collaboration of the various professional actors. Today, during his presentation, Tamas will be talking about this last initiative that is a great example of intersectionality in healthcare. So please, Tamas.
Thank you and welcome everybody, and thank you for having me here. I prepared with a short presentation and I would like to just share it on my screen. I don't know, now you can see my screen or not yet?
We can see it, not in the presentation mode yet, but we can see your presentation.
Okay, so I should start with the slide. Just a minute, please. So yes, I prepared with some words about our organization, that we are a homeless provider in Hungary, and we are one of the biggest one in the Central European region. Right now we have got like 38 units in 20 sites, and there are different kind of accommodations. Mostly of them are worse in the conventional model that was established in Central Europe, I think, when the crisis of the homelessness just arose, when there was this system of change, the political system change. So we have got temporary accommodations, day centers, outreach work, night shelters, and how our services was developed. We have got like supported housing programs now, and just to responding the needs of the homeless people, we needed to develop health care services as well.
Thomas, sorry, Thomas, just we are still seeing the slides, not in presentation mode, but we are seeing your PowerPoint window.
All right, but how is it? Because I can see it only just with with the, the presentation mode. So I haven't got a clue what to do with that.
I think you have to launch the presentation and then go back to Zoom and share the window of the presentation if it's possible.
So new share, all right, yeah, or not new share. Sorry for
no worries.
causing this trouble. PowerPoint.
Otherwise, we can use the, okay, perfect.
No,
What about now? Is it okay now?
Yes.
Yeah. Okay. So yeah, and now I would like to talk about what we know about the women among service users of homeless services. For example, it's a big problem that in Hungary we don't have got censuses where we can estimate the number of people who experience the homelessness. But in every year we have got, and I think it's since more than 20 years now, from since 1999, we have got a longitudinal research. Every year on the 3rd of February, we have got surveys that is asked from people who are using the homeless services all around the country. And from this research, we can have a picture about the phenomenon of homelessness and how is the living situation of homeless people. Usually we ask about income, how long they have been in homeless situation, and other basic data about them. And according to the result of this survey, we just know that the prevalence of women among homeless people here in Hungary, it's about 25%. It's changing from year to year. Sometimes it's a bit more, sometimes it's less. But what we know about the phenomenon of women homelessness, that is well known that it is more hidden than it is in the case of men. Usually they are in some kind of living situation with privately sorted out. And I think the number of the women who can be seen in the homeless sector is always depends on the services, how many accommodation they and services they offer for women. And for example, in BMSK, we have got more services for women, and that's the reason why the percentage of the women is higher than in other homeless services in Hungary. So in the last years, we tried to develop the services for women, and we have got a family temporary hostel where families, women with children and couples can live. We have got women-only accommodation services, 2 night shelters, accommodations for couples. They are accommodated in temporary hostels, and we are developing the social work just to try to respond better for the needs of women. For example, because there is a quite big percentage or that the women who experiencing homelessness has got an experience about gender-based violence, partnership violence, other kind of violence, and other traumas from childhood and other hard situations. So our social workers usually attend to PTSD trainings. We had the Pie for Shelter project, which was mentioned before, so I'm not going to talk too much about that because in the introduction there was some information about it. And in 2018, we carried out a women needs assessment in the services of BMSK, and this women needs assessment given us a picture how we could develop the services. And we have got regular workshop for the social workers to support women. And Erasmus Women and Homelessness Project was mentioned in the introduction as well. So I'm just going to tell that there were so many topics that we try to elaborate and where we try to find good practices, and after the exchange of them, some of them were adopted and some of them will be adopted hopefully. And one topic was the health issues and access to healthcare of women, and the gynecological healthcare was just like an initiative, I think, which was inspired from this project, as we saw not a bit different, but it's a similar project, which wasn't a gynecological care for women, but it was like a low threshold service where the health professionals met women on the street, and after that they invited them to their services for health check and for the necessary treatments. All right, and now I'm going to talk about why we thought that it's necessary to establish this kind of service. Because, as I mentioned, the assessment survey, we just had the result that 2 from 3 women haven't been in gynecological examination or breast checkup in the 2 years before the survey, and that we know that how I just mentioned before, that the prevalence of the traumas and traumatic experience are very high among women who experience homelessness. And as I mentioned, we have got these workshops, and from this workshop with the social workers, we have got so many reports that women have got barriers when accessing the traditional healthcare system. So we needed to try to do something to enhance their opportunities in this area. So when we had the possibility, I'm going to tell how it was just 1 year ago, or when we could start 1.5 years ago, when we could start planning, and after doing the activities for developing and establishing the service. So with this service, we want to give the opportunity for them to have right access for the gynecological examinations, and if there is necessary further treatments, in this case, we would like to support them to get these treatments. And we want to give access for them for birth control or other necessary medication, because how we know that in this vulnerable group, they live usually in very low income or without income. And this is and the fourth aspect, that we would like to develop our programs to just to respond for the needs of those women who are younger and who are pregnant, because in the normal healthcare system they face so many barriers when they would like to access to maternity care. So we would like to develop this service in this direction, and this service was in a collaboration with different organizations for the fundraising and social media campaign and the construction work, because it's not funded by the state. It was funded by private firms and private persons who joined to the campaign, and after that given donations, or there were firms who given us the necessary equipment. And as we thought that it's needed to be operate in a quite holistic way, because that was our experience, that we needed to work on the getting better access for the women, even to this kind of service, which is our own service. So our social workers and even the staff of the service was trained by an association who has got adequate expertise on this field, and we are working in cooperation with another association who support pregnant women who struggling substance abuse, and one of their colleagues is a part of our healthcare staff here. And the last part of my presentation, it's about how the principle of the trauma conscious approach are carried out in practice in our service. So as I just mentioned, that we needed to work in a quite holistic way. We set up a women reference network which involves social workers from every of our services, and they were trained to be able to talk about the issues of that women can face on their life journey, and the issues regarding to their health situation, especially the intimate health issues. Beside of that, the health professionals of the gynecological services, and together with the social workers who are part of the this team, were gone under training as well. And we after this we have got how the women can get access to these services, that we can give them appointments, and the social workers who are the reference people can give a direct appointment for them, or even if they haven't got a good relation to any of these social workers, or they don't want to talk about this kind of issues with social workers, they have got a possibility to call the service just by themselves. I have to tell that, which wasn't in the slides, that we have got only 3 days per month when we have got the opening hours, and in this availability time we can give appointments for 11 women for one day. So the other elements that we needed to establish a safe environment, so that is carried out by aspects like only women can enter to the service. I just mentioned that the health professionals are working together with the social workers, and they all gone through on a training about trauma, and on this training they were just observed and planned how all the steps going to be carried out when women arrive to the service and gone through on the examination. That's how the consultations will happen, to be as working as trauma-informed as it's just possible, because and besides the social workers are present in the waiting room all the time, they are the ones who answer the doorbell and accompanying the women who arrive to the service. And after that, they are in their role, try to engage them, try to talk, try to get contact with them to reduce the level of anxiety that can arise in this situation. It is with kindly and friendly and respectful communication, and it is very important that everybody who is in the service is always introduce themselves and talk about their role and what sort of help they can give to the person who arrived. The other important element is the design on the waiting room. the waiting room is not like a normal waiting room in other health services. People sit around tables, we offer teas for them, and usually they are talking to each other, because this is a normal situation here, that those who come to the examination arrive earlier, and after the examination, very often they don't want to go, they are just staying here and talk, and they feel how comfortable and safe here, I think.
I'm very sorry to interrupt, but I'm going to have to ask you to speed up a little bit.
All right, I think I have got, yeah, okay. Okay, speed up a little bit. Okay, I don't know where I just, okay, so other important thing that we used, not we, but the staff used simple language, avoiding the medical terminology. During the examination, every steps of the examination is always explained, and women have got rights to stay stop. We provide the patients a robe that they doesn't feel naked for a while. We have got a bathroom where they can have a shower, and we can offer clean clothes for them. And we have got 30 minutes for the examinations and for the consultation, but of course it's very often it's longer. Usually the doctor and the health assistant sit down together with the women who have gone through the examination. The doctor is never alone. He's always working with the assistant together, and they always pay constant attention to the patients, and their role just not only do the examination, just to stay and give a support for the situation. Okay, and then this is the last of my slide. So that was the elements of the trauma conscious approach, but we have got other kind of supports, like if after the examination it turns out that there is a need for more treatment, we try to support in this. We try to work out pathways to hospital care, and the social workers who are in the staff are available to support in this pattern, and they can even accompany to the women to the hospital, and we can give free medication and free contraception for the women who were here. And the other important aspect of the trauma conscious approach, that the staff the reflective practice is available for the staff. And I think this is the pictures, and I think I have finished with my presentation, and thank you for.
Thank you very much. I know that you will not be available for our discussion that we will have later, so I would like to warmly thank you for joining us and for sharing this this wonderful, very holistic and international intersectional initiative with us. I think that it is really inspiring that within this project you are showing that sexual and reproductive health is not something that is elective, but this is a part of really primary healthcare, and it should be available, accessible to anyone. So thank you very much. I'm really glad that you found some time to join us today for this webinar. And with that, we are finishing the part of presentation panel. Before we move to the discussion, I will hand the mic back to Lorenzo, who will briefly share with you the recommendations of the Resistire project that we came up with based on the results of our research. And later on, we will hopefully have enough time to discuss with our invited guests what are their thoughts, what are their opinions on the proposed recommendations, and whether there is anything that they think should be added or placed more attention to. So please, Lorenzo.
Agnieszka, thank you very much. And thank you for the wonderful presentations. I'm very curious to discuss with you what we have come up with as recommendations based on your experience, because they really are spot on. As Mateus mentioned before, there's a lot of synergies on the work that we have done and what you have experienced and observed firsthand on the field. So these recommendations, just as a brief and a quick overview of what they mean, are basically the end result of a very long research process that Agnieszka mentioned before. And they try to be as adaptive and as useful to any type of user. So one of the really the key points of these is that they're easy to interpret and useful for policymakers as much as grassroots movements. Of course, when we're talking about healthcare systems, it becomes a little bit more complicated from this point of view because they're big and complex systems. But what we've focused on here is first and foremost on a reconceptualization of healthcare through a holistic approach. And this means that policy objectives in healthcare should keep in mind of the impact that privatization has on the healthcare of a country. That's a fundamental and very important to learn from the experience of the pandemic, and that healthcare systems should have updated preparedness plans to face future pandemics, which keep in mind the epidemiological transition of the population and the health of every person and the needs of everyone. And that is specifically related to the fact that with the reality of our aging population, a healthcare system should be able to prepare itself for the event of a pandemic as much as the increase of healthcare needs of an older population. Of course, this is related directly to also a more systematic collection of data on vulnerable populations. And it was mentioned before that there's a big chunk of this of these people on which we have very little information about. And this starts first and foremost with the healthcare system, which need to be easily accessible to anyone, regardless of work status, immigration status, or living conditions. And this requires new up-to-date data on health and well-being of populations, which are considered hard to reach and not conventionally registered in national healthcare systems through national registration systems, which is usually how healthcare systems reach the population. And this is related also to the checkups and health needs that a population requires, which were mentioned in the presentation before mine. And then, of course, there's the leverage of community and local care, with Karen presenting such a wonderful example of this. And that's because decentralized care can be more reactive to the needs of a population and alleviate workload from central healthcare systems. And we've seen this happen exactly in during the pandemic, and how a problem like a respiratory disease, which spreads so quickly, like COVID-19, saturated the healthcare system so quickly, in part because community and local care were not as organized 3 years ago or as they are now, hopefully. And this also results in less waiting times and faster resolution for most non-urgent care needs. And finally, on a more structural level related to the population that we are looking at, but there needs to be better working conditions for healthcare workers. This came up more and more often in our analysis, as much as in our interviews. The fact that shortages of primary healthcare workers is created by the fact that their contracts are not fair, that they're put in a situation in which their work is a lot harder than it should be. So a healthcare system needs to improve these precarious conditions and keep in mind the importance of work balance life for these professions, especially after this pandemic. And then, of course, there needs to be a stronger focus on mental well-being and their risk factor related to these professions. So really an update of an understanding of this work. And lastly, but certainly not least, the stronger focus on access to good quality and non-discriminatory sex and reproductive health. And this has been a major theme in most of the work that we've done when looking at data on access to SRH. It needs to be more comprehensive. It starts with a training of which is more comprehensive on sex, sexuality, and gender at healthcare worker level, which makes it more responsive to which makes the healthcare system more responsive to sexual and reproductive health needs. And of course, recognize SRH as a fundamental right for every patient, which includes their self-identification as part of their medical record. I think that on this premise, I don't know if I'm the one that's supposed to launch the conversation, Agnieszka, but the part of the great opportunity that we have with Resistere and with this webinar is the fact that we can hear your inputs on this. So we're constantly trying to improve whatever we're looking at, and it's always such complex things that are all interconnected with each other. We're wondering whether we're missing the point, whether you think there's better ways to reach marginalized and outreach populations, and the speakers today are perfect to let us know about this. If there's more accurate recommendation on improving health and well-being for healthcare workers, or any thoughts or comments.
Thank you very much, Lorenzo. I have a feeling that each of this recommendation would actually deserve a fact sheet on its own. But let's hear what our invited guests have to say about it. So maybe we could start from the order of the presentations. So I will first direct the question to our representatives of the Community Health Workers Projects. I don't know if it is going to be Matthias or Karen, but please, if you could respond to the recommendations, share your thoughts on them, that would be highly appreciated.
Yeah, well, I will take care of this. If Karen, if you want to add something, feel free, of course, to do so. If there's a lot of background noise, I'm sorry. I'm at a conference, so I'm very sorry for that, but I hope it doesn't bother at the moment.
We can hear you very well.
Okay, great. So yeah, I read the recommendations earlier as well, and I think, as you said, every recommendation could be a debate in itself. I think so. That's it's very hard to just in a short matter give my things to say. How can we better reach marginalized groups, for example? I think it's complex because I understand the recommendation of the gathering of data. But of course, from the fieldwork, I already think but how? That's already my first thing. It's nice to say we do need more insight on vulnerable groups, and especially the ones that now we have no idea, refugees, people that really have no link to the system. But my idea is how to start with that. So that's something that I would recommend to really look into, because we know from our fieldwork that it's one of the things people are very hesitant about. People in vulnerable groups, they look at it with a certain mistrust on everything that has to do with gathering data and stuff. So it's a very tricky one, but I think it's very important. So that's one thing I wanted to say. The other one for me is reaching the vulnerable groups is one thing, but what we also see is that at times we can reach the vulnerable groups, but the care system is not in place. So we reach them, but we have nowhere to bring them. So I think the important thing is really to make sure the health system is reorganized and much closer linked. So I think what was just said about more local care and local organization of healthcare, it's a fact, but it has to be combined with the really systematic integration of one big health system, because that's one of the strengths that we experience now and also during the COVID pandemic. It's that there has to be a central organizing entity. Like we have, as mutualities, we are doing it now because we are working both in Flanders, Brussels region and the Wallonian region, and we learn a lot from each other. And so the local thing is very important. So we want to learn lessons and implement it in a local way. It has to be different in different cities. So that I agree upon, but I think it's important to keep a clear overview and to try to work as efficient as possible. And then one more thing, but that's just a detail because I'm working a lot on that, is I didn't really understand the first point about the privatization issue. So that's what for me might be a bit clear. Is the worry more about the fact that by so many private entities there is no link, or is there a worry about privatization in the sense of commercialization of health? So those are two things that for me are a different issue. The commercialization is to be avoided for sure. Privatization per se is not a big drama if it's organized in a correct way. So,
Yes.
but maybe it's easier if there's interaction or something, because I don't know if this is giving help or makes it even more
Absolutely.
difficult. So.
Thank you very much. I mean, first of all, I second everything that you've said, and I just want to emphasize that what we propose, we know that this is not a solution. This is not a perfect fix. This is just a direction. And so this is why we are also collecting those better stories, because we think that by showing those good practices and combining different stories from different countries, we can maybe come up with some ideas on how to get closer to more equitable, more accessible healthcare system. But we are aware, as I said, that it's not a perfect fix. Responding to your last concern that you've raised, what we mean is the second. So what we mean is that prioritization, it can lead to limited accessibility to those who cannot afford it. And as Mateusz said, the problem, for example, of sexual and reproductive health in Poland is that it is really expensive, and therefore it limits the possibility of a big portion of population to actually receive this sort of health support. Okay. But maybe here I will hand the mic
maybe one last thing. The better ways to reach the marginalized groups. I think there's a lot of work being done on that. So, but one thing that we notice that's very important, and that the community health workers themselves always say, is to take time. Time is the crucial aspect. And I think that links a bit with what you just said about the privatization, in the sense of becoming expensive. Taking time and not thinking always about has to be efficient, has to be fast. Vulnerable groups need a different approach. Then, well, not a different approach. Actually, every human being should have that approach, but some people don't mind. But taking time, make the people be seen, heard. It's a crucial one. That's last one.
Thank you very much. I think it also perfectly fits the last presentation that we've had. So the intervention of Tamas, who proposes a very comprehensive, very holistic approach to sexual and reproductive health for homeless women. But I wanted to ask Mateusz to maybe also, first of all, respond to our recommendations, but also to what Matthias just said about the problem of privatization.
Okay, so first, regarding your recommendations, I've pointed out some interesting topics I think I'd like to speak. First, you've pointed correctly that current funding scheme needs to move from the short-sighted project-based approach to more sustainable long-term solutions, because you know, the NGOs are often operate in the economy of scarcity, when there is always either shortage of people or money. And grants are given often for the project, but our work is not to do a project and go home, but mostly to replace the role of the state. And we have to work non-stop to help the community. And the current funding system, it's not helping us. Its leaves are in the lots of uncertainty, which is bad not only for the organization and capacity and operation, but also for the staff, basically. We also have to pay the bills and take care of our families, and it really strongly affects our mental well-being, that this uncertainty. Second thing I found interesting that used to get to eliminating policies that criminalize or obstruct women's access to services, such as abortion. Yeah, I totally agree. There's no point to punish women for having abortion, like here in Poland. Also, the international bodies emphasize this, like the CEDAW committee, for example, stated in 2017 that the criminalization of abortion is a gender-based discrimination, basically. And regarding this privatization, I don't know how the Western framework of the medical care looks like, but here in Poland, if something is private, it's also often non-accessible to most of the population. So basically, if the state doesn't fund the healthcare, that means the healthcare is not for the people here. Maybe there is some other strategies how to counter that, but I'm not aware of that. I'm not an expert. I just speak on from my experience as a patient.
Thank you very much for that. And with regard to the last thing that you've said, I also wanted to maybe change the topic slightly, but still obviously remain within the topic of access to health services. We are currently living through a different crisis as well, so the Russian invasion on Ukraine. And I know that the recent report of national and international human rights organization also raised this issue that refugees, women refugees who are currently living in Poland, in Hungary, in Slovakia, they struggle to have access to sexual and reproductive health services. And I assume that the cost of those services, at least in Poland, is also part of the equation. Do you think that the lessons learned during the pandemic for your organization, it somehow helps right now to handle this current crisis and be of more support? Are there any similarities, something that you can use for future crises?
Yes, the COVID pandemic was a training for us, and when the war started, we had many Ukrainian refugees which were seeking the option for a legal abortion here, because many of them were the victims of the school of violence from the Russian soldiers. By law, they are entitled to obtain abortion here in Poland, but because of the language barrier and not having knowledge of how the system works in Poland, they were not, and they were basically banned from having an abortion. And also, you've said about the holistic approach, and I think here in Poland it's still more like a power dynamic between the doctor and the patient, and the Ukrainians weren't aware of that, and this only multiply the problems they were facing, and we were trying to help them with that. I don't know if it does answer your question or not.
Yes, thank you very much. I mean, I know that this is also a very tough question to answer. But thank you very much. I would like to go back for a moment, maybe to what you've said about the economy of scarcity, and this is also something that Karen mentioned in her presentation, that there is a need for sustainable funding. So I wanted to ask you, Matthias, how it is being handled in your project, because maybe I misunderstood, but the community healthcare workers, they are regular employees. They are being paid for their work, right?
Yeah, but I think it's also the same. So they are paid workers. Huh? So we have the 50 community health workers and the coaches. They are paid by a budget that's been foreseen by the Belgian government. But the same thing again. We started in 2021. First, the budget was foreseen for 1 year as a project year, then a second year, and now we have a prolongation till the end of 2025. So at the moment, the funding would stop. Also, yeah, we cannot no longer pay these people, and so the project would also stop. So I think it's the same issue that we see, but we are really advocating by having the positive results that we had now. We really hope and we're really working hard on making sure that it doesn't remain a project and it becomes an integral part of the healthcare system in Belgium. That's really our ambition, and that's what we're working for hard every day. But for now, it's just we are guaranteed the end of 2025 with our 50 workers. We would like to expand because the needs are much higher, but then the budget has to be there first. So.
Of course, we will keep our fingers crossed for the possibility to prolong the project. We still have a couple of minutes, so I would like to ask whether you, Lorenzo, or anyone in the audience has any questions. I can see that Roberto is raising his hand, so please.
Yes, first of all, thanks everyone for the presentation because they were amazing. My question is for Karen and Matthias, because I loved, Karen, when you called the community health workers lay health workers, because it sounds with something that I'm familiar with. And I wanted to ask you if there are occasions in which these lay health workers can share their knowledge with the expert care workers.
You mean expert care workers is like the traditional, the doctors?
Exactly,
yeah.
exactly.
Occasions, it's not like we have organized like clear setups or meetings or whatever, but the idea is exactly that they share their knowledge in one-to-ones with the doctors that they try to find the link to, or with the organizations they find the link to help them understand why, how and why the target population acts like they act, and how they should be open and try to work around it, so that once they are in touch with the population, the community health worker has brought them in touch, basically the expert can then deal with them themselves in the appropriate way, because that's where now it lacks a lot. So we try to educate, well, educate is maybe the wrong word, but it's mostly on a one-to-one basis. Although we have also had, and that's interesting, I think on 3 or 4 occasions, I don't know exactly, given a guest lecture which was done by a community health worker for I think the 3rd-year nursing students in Ghent, and also the 2nd or 1st years, I don't remember, medical students in Antwerp. So we try to I think it's important in the curriculum that it comes as fast as possible and not only later. So we do set in, we do put a lot of emphasis on that as well. We try at least. Yeah.
Thanks a lot.
Cheers.
Thank you very much. I think we have time for one last very quick question, if there is any. I can see that Marina is raising her hand, so please.
Yes, thank you, everybody. This was very interesting and inspiring. I had a couple of questions, but maybe just one was about the neighborhood focus of intervention, which was presented by Karen, and not by target groups. So this is, of course, very interesting. And I was wondering whether you could observe dynamics or interesting, things coming out of the interaction of different target groups, so different needs, etc., in this holistic and comprehensive approach. Then I was very interested in the Budapest biking mafia, which was presented by Tomas, because we know how cycling associations are active in environmental issues, and but this link with the health activism, and that was very interesting, but probably there's no time to go deeper into that. Thank you, everybody.
Thank you very much, Marina. So for the first question, I think this is again for Matthias and Karen.
Yeah. It's not an easy question to answer, to be honest. Did we see dynamics? What we really see is different dynamics in different neighborhoods, even within cities. But we also, the idea is very hard to work on that level, like to involve the whole community. But all our community health workers have a certain background. And so for us, it's also, as a project, not always easy. You can see if someone has a background from, say, with from a Moroccan language, Berber language, although more the Arabic languages, you see that also the population in the community that attracts the easiest is that population. We make it broader, but you can see it, and you see it very good. And the figures, we have a website, and the figures will be uploaded there soon in English too. And there you can see in detail that it's a very diverse population that we have. I think it's, I don't know if Karen, you mentioned, but it's 107 different nationalities that have been impacted by our actions, and that is because we work in these diverse neighborhoods. But we do notice that we have a neighborhood where there's a lot of Turkish people, a lot of Moroccan people, a lot of Italians, and we have no community health care at this point masters the Italian language, and you see that creates a barrier also there. So I think language is something we see, and it can also be our native language, but in a different way. With people with a poverty background talk and think differently than people who have not that experience. So I think one thing to reach those vulnerable groups is to get that, and that also creates it's a different dynamic, of course, in the different groups. If you have a very homogeneous, I don't know if it's an English word, but okay, I hope you understand what I mean. If like all the people are more or less from the same background, it creates a different dynamic than when you have different backgrounds. So it's hard to give one example. I don't know, Karen, if you have an example come to mind, also in Dutch that I can translate, but so I stay a bit too general for your question, Marina, but I think there it's where I could also provide you one with one later, which a community health worker themselves could provide to you. So.
Thank you very much. And unfortunately, we are anyway heading towards the end of the webinar. So even if there are any other questions, I'm going to have to stop the audience and just encourage you to move the discussion offline. I would like to, first of all, thank you all for joining, especially, obviously, our special guests, our invited speakers, for those inspiring testimonies that you've shared, and for the work that you're doing constantly in order to support vulnerable and marginalized groups. As I mentioned at the beginning of the webinar, our project is heading towards the end. So in June, on the 20th and 21st of June, we will be organizing the final conference of the Resistire project. It will take place in Brussels, and we will be focusing on the better stories of inspiring policy and societal responses to the crisis. We will have different panels that are focusing on the most important areas that we've identified within the 3 years of the project. One of the panels is dedicated to the topic of healthcare, to how to bring care back to healthcare, how to make healthcare more patient-centered and more holistic. So I would like to, from here, invite all of you to join us. It is possible to either participate in the conference in person or online. I think that the link to the registration has been just shared by my colleague Roberto. So I encourage all of you to take a look at it, and we would be honored, we would be pleased to have you there with us. The recording of today's webinar will be available online, so I will make sure to share it with you. I'm sure that we will stay in touch. You will definitely hear back from me again. So once again, thank you very much, and have a nice day, everyone.